Good evening, ladies and gentlemen. Welcome to the 130th Airlangga Webinar Conference Series in collaboration with ISMINS, with the topic of Advances in Minimally Invasive Neurosurgery. My name is Aslia, along with my friend Rifat. We are the organizing committee members of this evening's webinar. This webinar is organized and initiated by the Faculty of Medicine, Universitas Airlangga, in collaboration with ISMINS. Before we proceed to the main event, we will announce some of the rules regarding the certification and Q&A session of this webinar. Rules for certification. 1. Full participation during this webinar is required. 2. Your attendance will be recorded by the Zoom application. And 3. The certificate will be sent to your registered email address. And by the end of this webinar, participants are required to fill a questionnaire, which the committee will send in the chat box. Next. Rules for Q&A session. Use the Q&A box in the middle of your Zoom panel to write down your questions, and questions will be sorted and discussed after each of every lectures. Thank you for your participation, and we sincerely hope you enjoyed this webinar. And before we proceed to the main event, let us take a picture together to commemorate the start of this webinar. To all of the panelists, can you please kindly turn your camera on? Okay, and let us take a picture in 3, 2, 1. One more. Let us take a picture in 3, 2, 1. Okay, thank you very much. And also, please, I will introduce our host for today's webinar. Please, for Professor Dr. Asra Al-Fawzi, the time is yours.
Okay, thank you for the committee, and welcome, and good afternoon here, maybe good evening in Japan. Thank you again for the 3 speakers that joined this webinar. Professor Ishihara from Yamaguchi University, and also Professor Takegoto, my old friend, good friend from Osaka City University, and also Dr. Selvi from National Brain Center. And also I will introduce to the moderator, Dr. Rahadian, Dr. Rohadi, and also my friend Deepak from India. Thank you for join and support this webinar. And this time the theme of the webinar is Advances in Minimally Invasive Neurosurgery. And yes, we have 3 speakers, and for each presentation we'll continue with a question and answer. So each session will be managed by each moderator, and I think the first session will be moderated by Dr. Rahadian. So please, for all participants, enjoy this webinar, and we can start the first presentation. Please, Dr. Rahadian, you can start the first session. Thank you.
Okay, thank you, Professor Asra. Good afternoon, everybody. The first speaker will be Professor Ishihara. He is a professor and chairman from Department of Neurosurgery, Yamaguchi University School of Medicine. Professor Ishihara will talk about the perfusion therapy based on penumbra. Professor, time is yours.
Okay, thank you for your introduction. I will start my topic. Can you see my slide? Okay, no? Can you see my slide?
Excuse me, Prof. The slide is still white. We can't see your slide yet.
You can't see my slide?
Yes, we cannot see it, Prof.
Oh, sorry. You can't.
Now we can see it. It's okay now.
Okay.
Maybe
Okay.
slideshow, Prof. Now slideshow.
Mm,
It takes time maybe. Or
is it okay? No?
not yet.
Can you see the map?
I'm
No?
Not
sorry,
yet.
Prof.
Please wait.
Can you see? No?
I'm sorry, Prof. We cannot see your slide on the slideshow, but we can see it before the slideshow.
Oh, sorry.
Now we can see it.
Maybe can you hear me now?
Yes, clear.
Now
Yes, sir.
okay. So maybe I have to present this manner. Okay. Okay, now can you see my slide and can you hear me?
Yes.
Okay.
Okay, okay, Professor.
Okay, so my topic is reperfusion therapy based on penumbra assessment. First, I would like to introduce my my city and my hospital. Our hospital located west end of the main island of Japan. Here. Next city is Hiroshima, and the other side is Hakata. Osaka is here, and Tokyo is here. Our city is an industrial city. We have many factories near the sea. Our hospital is near this industrial area. Our hospital has 754 beds. Our neurosurgery had 571 operations last year. One-fourth is craniotomy, and one-third was endovascular treatment. So moving on my topic, when cerebral large vessel is occluded, neurons are rapidly lost as stroke progressed over time. Cerebrum has 40 billion neurons. It is said that 32,000 neurons are lost per second. 120 million neurons are lost per hour. So it is called time is brain. The ischemic penumbra is defined ischemic tissue which is functionally impaired and is at risk of infarction, but has the potential to be salvaged by reperfusion. This concept was proposed by Astrup and Professor Lindsay Simon in 1977. Purpose of hyperacute stroke treatment is to rescue of the penumbra. The concept of penumbra was gradually established but we did not have imaging method of penumbra estimation. Because we did not have way to rescue the penumbra, we did not need penumbra estimation. In 1995, TPA was approved in United States, and in the decades since 2000, thrombectomy device had developed. Maybe you know this, but I show you reperfusion therapy. This is animation. Occluded site stent retriever is working like this. This is the case. Balloon guiding catheter is introduced to internal carotid artery, and this case was M1 occlusion. Microcatheter crossing the occluded region. And now open the stent retriever here. And retrieve the stent. Relatively easily, we can recanalize the occluded site. Penumbra was only a concept because we did not have method to recanalize. We did not have to evaluate the penumbra, but IVTPA and thrombectomy had made the penumbra evaluation necessary. How to know the penumbra? As penumbra estimation method, the first one is MCA 1/3 rule. This method was proposed in ECAS trial. In criteria in this trial, it is written patient with acute ischemic hemispheric stroke and moderate to severe neurologic deficit without major early infarct signs. This without major early infarct sign is less than 1/3 of the territory of the middle cerebral artery. As you know, MCA territory is a blue color, this part. On initial CT of IC or M1 occlusion patients, only small early ischemic signs means remaining MCA territory may be the penumbra. Sorry, today the animation cannot work. This case, small ischemic region, it means this case has penumbra. Next penumbra estimation method is aspects. This method is an improvement of the MCA 1/3 rule. MCA territory is evaluated on a 10-point scale. as you know, 10 points means no early ischemic lesions, and 0 point means all of MCA territory already become infarction. Based on clinical trials, aspects 6 or more was considered indication for endovascular treatment. This report shows relation of aspects and ischemic volume. And aspect 7 is about 25 milliliter infarction volume. On CT or MRI of IC or M1 occlusion patients, aspect score equal or more than 6 means penumbra exists. In 2014 and 2015, 5 trials reports positive results of endovascular treatment for early IC and M1 occlusion. Meta-analysis of these 5 trials showed OR of favorable outcome was 2.49. It was a significant result. When treated with only IVTPA, only 3 out of 10 patients were able to walk and go back home. When treated with IVTPA and endovascular treatment, 5 out of 10 patients were able to walk and go back home. This figure shows indication of reperfusion for IC and M1 acute occlusion. The horizontal axis represents time from onset, and the vertical axis represents infarct volume. From 5 RCT results, the effectiveness of endovascular treatment was proven this part. Early and not large ischemic core. Early and not large ischemic core. Next penumbra estimation method, number 3, is perfusion image. Various parameters have been studied to estimate the penumbra. Among them, Tmax has been shown to be a best parameter so far. This study, they analyzed not recanalized 33 patients with IC or M1 occlusion. They analyzed MR perfusion image in acute phase and FLAIR images in chronic phase. As you can see, Tmax 4 to 6 green part. This green part developed infarction, but Tmax 2 to 4 blue part did not develop infarction. So in the area with more than Tmax 4 to 6, the penumbra may exist. Rapid software from ISKEMA is world famous, but there are several other software available. Because collateral flow varies from patient to patient, perfusion analysis is considered the most reliable method so far. The effectiveness of perfusion imaging is particularly highlighted by DEFUSE-3 trial. This study was examining the effectiveness of endovascular treatment for delayed phase of large vessel occlusion. inclusion criteria between 6 and 16 hours after the time last known to be well. Perfusion analysis was performed using rapid EBT group and vascular treatment group had remarkable good outcome. Because the penumbra was confirmed before treatment, the results were obvious. From the result of 𝑑𝒓𝒐𝒃 and DAWN trial, the effectiveness of endovascular treatment was proven this part. Delayed time window, but not large ischemic core. And next interest was this part, early large ischemic core. In Rescue Japan Limit study, patient with early timing from onset, 4.5 hours, but large ischemic core were included, aspects 3 to 5. Primary endpoint was modified ranking scale 0 to 3 at 19 days after onset. Endovascular treatment group had remarkable good outcome. This study proved the effectiveness of endovascular treatment for patients with large ischemic core, aspects 3 to 5, and early time window. From Rescue Japan Limit, the effectiveness of endovascular treatment was proven this part. Large ischemic core, but early time window. After Rescue Limit, 5 trials of endovascular treatment for large ischemic core were reported until this year. As shown in this table, almost all studies had positive results. 3 trials included delayed time window patients, and �ＲASTE trial included aspects 0 to 5. Aspect 0 means all of MCA territory are ischemic core, so it means endovascular treatment is effective even in the patient almost without the penumbra. Based on these trials, now we have to treat all patients with IC and M1 occlusion. This is a scene from the World Series. Yankees fan snatched foul fly ball from the player. Of course, this was a serious violation. Regarding large ischemic core, within 24 hours, it looks everything, whatever, okay. But I don't think so. Maybe you have same impression. Because I participated in Rescue Japan Limit study, I analyzed about time in this study. 100 patients in the endovascular treatment group were divided into favorable outcome group and poor outcome group. From our analysis, earlier recanalization, better outcome. The likelihood of modified ranking 0 to 3 at 90 days declined with longer times from onset to reperfusion. For favorable outcome, recanalization must be achieved within 360 minutes after onset. Regarding time course, there are several variables. Theoretically, onset to recanalization is most important factor, but from our analysis, the most important time was puncture to recanalization time. This means better endovascular treatment, better organized professional team can get results. The effectiveness of endovascular treatment for patients with large ischemic core has been demonstrated, but ADL independence was achieved in only about 15%. Now we have to consider how to identify patients who will improve and to treat such patients. This case is 79-year-old female. She developed disturbance of consciousness, aphasia, and right hemisphere paralysis. She was transferred to a hospital by ambulance. This is diffusion image on admission. As you can see, large ischemic region in left MCA territory. She had left IC terminal occlusion. Immediately we used stent retriever. We got thrombus and achieved good recanalization. Her symptoms improved after endovascular treatment, and this is the diffusion image of next day. As you can see, diffusion positive region was disappeared. This phenomenon is called diffusion reversal. Generally, the region ADC value lower than 620 are considered as ischemic core, but there might be difference in brain tissue damage depending on the magnitude of the decrease in ADC values. These two cases are the same NIH score. This case has faint DWI positive region, and this case has clear positive region. Rapid software diagnosed similar ischemic core volume and similar Tmax more than 6 second volume. These cases underwent thrombectomy as you can see, both cases were TK3, but the results were different. These color maps are created focusing on the difference of ADC value. As you can see, clear positive region has lower ADC value. So we analyzed ADC value of the patient with low aspects. We performed retrospective study. We analyzed patient with large ischemic core and achieved good recanalization. Subject was 48 patients. 18 patients were favorable outcome and 30 patients were poor outcome. Difference of these two groups were age and onset to door time and onset to recanalization time. We analyzed several ADC threshold and made AUC curve, and the strongest correlation was with ADC threshold less than 540 volume. And multivariate analysis for predictor for favorable outcome showed ADC threshold less than 540 volume was the strongest predictor. Our results indicate that ADC less than 540 volume rather than ADC less than 620 volume may be good indicator for patient with large ischemic core. As you know, ADC value are determined by the amount and velocity of water molecule. In normal condition, water molecule can move freely in intracellular space. But in ischemic condition, cells swells and water molecule cannot move freely in intercellular space. It causes decreased ADC value. We have to keep in mind ADC value indirectly reflects ischemia. We just looking the movement of water molecule, not cell itself. Our results may indicate in early time window the penumbra exists in the area ADC 540 to 620. When ischemic region was mild positive diffusion image and vascular treatment may be effective. This may be one of the treatment decision maker. This is a summary. Salvage the penumbra is the goal of acute stroke treatment. Penumbra assessment is difficult in acute setting, and vascular treatment is effective even in patients with large ischemic core. Patient selection required to get good result efficiently. There is a possibility that ADC value may be useful to select patients with low aspects for thrombectomy. Thank you for your attention.
Thank you, Professor Shihara. Very nice presentation and very informative. Now we open for discussion. Please, from audience, you can raise hand or type the question in the Q&A.
Dr. Ardian, there is
Yes.
a question in chat box.
Okay, the book. Chat book. Maybe we, Panitia can help to open the chat. I cannot see the question in the chat.
Okay, I
Oh,
will.
yes, I can see it. We can see the question from Dr. Julius Hermanto. Professor Shihara, recently we encountered an aneurysm like lesion at M2 before casual, just proximal to the thrombosis during the mechanical thrombectomy. Can be converted into open surgical embolectomy. In your opinion, what should we do in this condition? This is the first question. The second question is, in the case of acute stroke with intracanal stenosis, do we need to perform bypass or stenting in addition to MT? Do you also rely on the susceptibility vessel sign before intervention? This Professor, this is the question.
Yes, it must be a very difficult situation. But if we can know the patient has the aneurysm at occlusion site, maybe we can make image from T2 MRI image. So maybe in this setting, maybe we will perform endovascular treatment. It is very dangerous, but maybe if we perform craniotomy, it takes a long time, so maybe we will do endovascular treatment.
Okay. For the second question, maybe.
From Prof. Asra, Doc.
The other question, in the case of acute stroke with intracranial stenosis, do we need to perform bypass or stenting in addition to MT? In addition to mechanical thrombectomy? This is the second question for the same if we have intracranial stenosis, do we need to perform bypass or stenting in addition to mechanical thrombectomy?
Sorry, we encountered this one. In case of failed thrombectomy, use rescue. I see. Sometimes, maybe in a country, around 20% of patients is atherosclerotic occlusion. So usually, after thrombectomy, the region is re-occluded. In such case, we usually use balloon catheter and we performed angioplasty usually. Only in small cases we have to use rescue stent, but the result is not so good because of sometimes stents make thrombus, so we usually do not use stent, rescue stent.
Okay, thank you. Maybe you would also answer the third question. We also rely on the susceptibility vessel sign before intervention.
Medication means antiplatelet therapy, no? When we suspect the patient with atherosclerotic occlusion, we use double antiplatelet therapy. Okay.
Okay, thank you.
Okay.
Thank you. So that's the last question, maybe from Professor Asra. Professor Isera, in your experience, is there any complication in this procedure and how we can avoid?
Sorry, which one?
From Professor Asra. In your experience, is there any complication in this procedure and how we can avoid?
Which one? So, from Afghanistan? Do you come? No. Sorry, I can't see.
You can
Sorry.
see the chat box.
Can you read the?
Yes, Professor. You can hear me, Dr. Hadi?
Yeah.
Clear?
Second question from Professor Asra. Professor, in your experience, is there any complication in this procedure and how we can avoid it?
Yes. Of course, we have some experience of complications. Most severe complication is perforation of artery. In such case, we have to occlude the artery. So we cannot open, but we have to stop the bleeding. So in such case, we can't rescue the patient. Maybe in our country it is said about 1%.
1%.
1%. We have perforation.
Thank you, Professor. Because of time, we have to close this session.
Any second, another question, Dr. Radian, in the chat box.
Yes, but time is limited because we have to move to another speaker. And maybe, Professor, if you don't mind, please answer the question via chat box, and we can continue to the next speaker. Thank you very much, Professor Isera.
Thank you, Professor.
Yes. Back to the host, please, Dr. Asa.
Okay, thank you, Dr. Hadian. And please, we move to the second session. Dr. Hadi.
Yeah, Professor. Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, good evening, everyone, and welcome to this session in ISMIN and 𝑰𝑚𝑖𝑛S webinar series collaborative webinar. Today, we will talk about existing advance in minimal invasive neurosurgery, especially how to treat complex brain condition with lesion in invasive method. I am very honored to introduce our second speaker for today, Professor Takeo Goto. Our sensei is very famous in Indonesia. Professor Goto is a professor and chairman at Osaka Metropolitan University Graduate School of Medicine in Japan. He has many years of experience in neurosurgery and is well known for his working in treating skull-based tumor using endoscopy and microscopic technique. He's a hybrid surgeon in the skull base. He's also a leader in several international neurosurgery organizations, making important contribution to the field. In this session, Professor Goto, we will talk about the endoscopic approach for the skull-based tumor. This is a very challenging area, especially in neurosurgery, because of the complicated anatomy and important structure of, especially in skull base. Professor Goto, we will share his expertise and show us how endoscopic method and improving treating the patient. Please feel free to write down any question during the talk. After his presentation, we will have a Q&A session where you can ask your question. Now, let's welcome Professor Takegoto. Time is yours.
Thank you for kind introduction of me. Today, I'm very happy to have opportunity to present my work in this webinar because we have many friends in Indonesia. So my
Yeah.
topic is today the endoscopic skull-based approach. So I will share my screen at first. Okay, so can you see my slide?
Yes, Prof.
Okay, so today my topic is various kind of endoscopic approach for skull-based tumors. As already we know, the recently endoscope can offer the panoramic, wide and clear view around the deep-seated area. So this instrument is very useful for safe resection of skull-based tumors. So today my topic is about endoscopic endonasal approaches and also endoscopic keyhole transcranial approaches. At first, I will show our endoscopic skull-based approaches. Of course, I'm the skull-based surgeon, so I frequently use a microscopic skull-based approach for resection of the skull-based tumor. But if the region located the pure central skull base within this circle, which connected all neural foramen, surgical resection by the transcranial approach very challenging. But if we access this tumor by the endoscopic endonasal approach, we can safely resect it out such kind of the tumor. The typical case is a craniopharyngioma. This 67-year-old female referred to us with the chief complaint of the visual disturbance. But if we access the craniopharyngioma through the endoscopic endonasal approach, we can directly access within the circle of 𝑰𝑺. But sometimes the bilateral posterior clinoid can be very large obstacle to access the lateral margin of the tumor. So I drill out the bilateral posterior clinoid and also drill out the dorsum sella to make the space around the entire area of the circle of 𝑰𝑺. So we can safely resect it out the endoscopic endonasal approach. I will show our surgical video. Already bone work was finished. This is the sella floor. We gently elevate the pituitary gland upward to expose the dorsum sella and bilateral posterior clinoid. We safely drill out the posterior clinoid. Then we dissect the pituitary gland from the medial wall of cavernous sinus. And after mobilize the pituitary gland to the left side, I cut the dura mater behind the dorsum sella. So now we already within the circle of the 𝑰𝑺. So all critical structure is the lateral margin of the tumor. We can find out the dissectable plane between the tumor and the critical structure. So I carefully dissect the tumor. In this case, we can dissect the pituitary gland and stop. And all tumor was safely resected out. So our endoscopic endonasal approach very useful to resect such kind of the retrochiasmatic craniopharyngioma. Tumor was nicely resected out, and also we can preserve the pituitary stalk and gland. This is our paper, How to Drill Out the Posterior Clinoid Process and the Endoscopic Endonasal Approach. We published it to the JNS. This is another case of the large diaphragm cella meningioma, not tuberculum cella, not frontal base meningioma. Attachment of the tumor is a diaphragm. In such cases, tumor severely compressed the hypothalamus, and all tumor located within the circle of Wills. In such situation, transcranial resection very challenging and very risky to damage the perforator from the ICA. But if accessed through the endoscopic enonasal route, we can directly reach the diaphragm cellar. So I will choose the endoscopic enonasal approach. At first, I widely drill out the bony structure and then cut the dura around the cellar floor. We mobilize the pituitary gland to the right side, and this is the diaphragm. So at the initial stage of the surgery, we completely detach, devascularize the tumor. So when we dissect the tumor from the surrounding structure, we could not encounter the bleeding. Tumor was already devascularized. So we carefully dissect the tumor from the PCOM and perforator and critical structure. This is an oblique chiasma. We carefully dissect, and finally all tumor was resected out, like this. In case of the meningioma, after resection of the tumor, dural defect was very large, so we have to water tightly seal the dural defect. This is an important step for safe resection of the tumor. We put the fat tissue to subdural layer and make the knot outside the nostril and slide in the knot to deep seat area. And finally cover the septal flap like this. So all tumor was nicely resected out. In this case, we can could preserve his memory and pituitary function, and can prevent the CSF leakage. We published a surgical technique, how to make the knot outside the nostril and slide into the deep-seated area. We published this technique to World Neurosurgery. Then this is a lower clival meningioma. In such case, if we access a transcondylar approach, we have some risk to damage the lower cranial nerve. And if we choose a combined transpetrosal approach, we have some risk to damage the sixth nerve. But in this case, attachment of the tumor is here. So if we just access the tumor from the endoscopic enonasal approach, we can directly access the attachment of the tumor. So we choose the endoscopic transclival approach. We widely drill out the lower clivus and also include the jugular tubercle. I will show our surgical video. I carefully drill out the all bony structure around the lower clivus and then cut the dura like this. At that time already most feeder was coagulated. So this case tumor was very fibrous, but we not encountered bleeding. This is very important. So we can resect the tumor without the bleeding. This is the basilar artery, and this is the medulla oblongata. We resect the tumor step by step, like this. Now we reach the tumor ventral side of the hypoglossal nerve, and this is the tumor ventral side of the vertebral artery. Endoscope can offer a very clear view, so we can safely resect such kind of the fibrous tumor using the QSAR. So now finally we reach the lateral margin of the tumor. We expose the sixth nerve and then expose the seventh and eighth nerve, like this. So now we resected out the most part of the tumor very carefully, like this. This is a post-op MRI. Most part of the tumor was successfully decompressed, and her symptom was improved. She can eat the food. just the day after the surgery. So this endoscopic transcriber approach very less invasive procedure to her. Now, in this paper, we measure which part we can reach by the endoscopic and nasal approach, measured by the voxel-based region mapping. Red area showed that we can reach this part by the endoscopic and nasal approach, and the blue area can be safely reached by the transcranial approach. This is another case of the cavernous sinus chondrosarcoma. This tumor occupies the entire right cavernous sinus, but origin of the tumor is bony structure around the lower inferior part of the cavernous sinus. So endoscopic and nasal approach very reasonable access. Now we choose the trans-pterygoid approach on the right side. This is the base of the pterygoid process. We drill out the base of the pterygoid process and completely expose the paraclival carotid artery like this. This is a cavernous sinus, and this is a cavernous sinus, and this is a cella floor, and this is a tumor. After cut the dura, lateral side of the cella floor, we open the cavernous sinus like this. So hard part of the tumor was carefully dissected from the ICA. This is a carotid artery. We already drilled out the bony structure around the carotid artery, so we can gently mobilize the carotid artery to the lateral side. So we remove the tumor very carefully like this. In this case, all cranial nerve pushed to upward or lateral side. So medial corridor to the cavernous sinus, very safe corridor to remove the tumor. And this is the tumor lateral side of the ICA. We cut the dura, lateral side of the ICA, and carefully dissect, not injure the abducens nerve. We dissect the whole tumor like this. Finally, we can, of course, preserve the carotid artery and remove the all tumor, and also preserve the cranial function. Flow was confirmed using the ICG. This is a post-op MRI. Tumor was nicely resected out. How to mobilize the carotid artery is very important to resect the lateral skull base. So we publish this technique to World Neurosurgery. Then my topic moved to the endoscopic keyhole approach. At first, I will show our endoscopic subfrontal approach. I usually put the incision around the eyebrow and make the craniotomy with the size of 3 centimeters. And then we insert the endoscope around the frontal base. Under the endoscopic view, we can get the clear view around the paracella area. We can confirm the both optic nerve and the cella through. So tumor around the paracella area can be safely resected out this procedure. I will show this technique. This is a tuberculum cell meningioma with a dominancy on the left side and a tumor embedded to the left optic canal. So I choose the left subfrontal keyhole approach. At first, I put the craniotomy with the size of 3 centimeters and gently insert the cottonoid around frontal base. This is the frontal base and attachment of the tumor. And this is the optic canal. Endoscope can offer clear view, so at first I carefully drill out the superior wall of left optic canal. Now optic canal completely opened. I cut the dura to decompress the left optic nerve. This is an ipsilateral optic nerve, but this approach we can confirm the medial surface of the ipsilateral optic nerve. This is one of the benefits of this approach. After decompress the optic nerve, we continue the debulking of the tumor and detachment like this. Finally, we reach the contralateral optic nerve and open the canal like this. So now we confirm all tumor was successfully resected out like this. Postoperatively, the all tumor was nicely resected out. This approach also available for resection of the olfactory groove meningioma. I choose the same procedure. At first, I put the eyebrow incision and put the craniotomy with a size about 3 centimeters. And then we insert the endoscope to the frontal base. This is the frontal base. At first, anyway, we devascularize the attachment of the tumor at the initial step of the surgery. And then we dissect the tumor from the frontal base. Tumor was already detached, so we not encounter the bleeding like this. After decompress the tumor, we can carefully dissect the tumor from the frontal base. We continue the debulking and dissection. Finally, all tumor was detached like this, and we can also preserve the olfactory tract in this case, like this. This is a olfactory tract we can preserve, and then all tumor was resected. Postoperatively, skin incision was very small, and patient recover quickly. So this procedure also very useful. We published this technique to the also World Neurosurgery. And then my topic is transorbital approach. This tumor completely occupies the lateral cavernous sinus. In such situation, endoscopic transorbital approach also very useful. I choose the right transorbital approach. This is our transorbital approach. We cut the skin below the eyebrow and expose the orbital rim. In our transorbital approach, we combine the frontal craniotomy and make the space. This is the right side. This is the orbital rim. We cut the orbital rim and small frontal craniotomy like this. And then we drill out the sphenoid ridge. And then we reach the superior orbital fissure. This is the orbiter. This is the superior orbital fissure. After cut the main orbital band, we can peel off the dura mater, and surgical field is very similar of that of microscopic transcavernous approach. So we can just expose the tumor like this, and then perform the internal debulking. This case, pathology was a schwannoma, so subcapsular resection was achieved very safely without the damage of another critical structure. We continue the dissection like this, and then all tumor was nicely resected out like this. A small dural defect was covered duragen like this, and fix the fibrin groove like this. And then we finish the surgical procedure. Postoperatively, all tumor was nicely resected out through the transorbital route. So this is also less invasive procedure to access the lateral margin of the cavernous sinus. We published our surgical video of our transorbital approach. Then my topic is endoscopic keyhole anterior transpectoral approach. We put the skin incision around the frontal base, temporal base, and make the craniotomy with a size of 3.5 centimeter, and then we insert the endoscope to the temporal base. We can confirm the 𝑾𝒆𝒃𝒊𝒂𝒓 triangle, and then after drill out the 𝑾𝒆𝒃 triangle, we can open the Meckel cave and also cut the superior orbital fissure. Finally, we expose the trigeminal nerve from Meckel cave to brainstem. So this view is very similar of the microscopic anterior transpectoral approach. This is the very small petrous apex meningioma causing the uncontrollable trigeminal neuralgia after gamma 9. So I choose the less invasive resection of the tumor. I will show our surgical video. At first, we put the craniotomy with a size of 3 centimeter, and then insert the endoscope to the temporal base. I stimulate the GSPN, and then cut the dura medial side of GSPN like this. And then we drill out the anterior petrous bone under the endoscope. After that, we coagulate and cut the SPS. So finally, tumor was detached. So we insert the tumor removal. We not encounter the bleeding. I additionally cut the dura to confirm the horse nerve, medial side of tentorial ridge like this. And then we dissect the tumor from the inferior surface of the tentorium, and then all tumor was resected out like this. This case, tumor compress the SCA, and SCA compress the trigeminal nerve. So we mobilize the SCA of the trigeminal nerve, like this. We insert the endoscope more deep side. We can confirm the 6th nerve and 7th and 8th nerve. So this view is very similar of the microscopic anterior transpectoral approach. Tumor was nicely resected out, and her trigeminal neuralgia completely disappeared. This approach also very useful for resection of the trigeminal schwannoma. This tumor occupies a Meckel cave posterior fossa and infratemporal fossa. But if we just use the endoscope, we can observe the 3 parts at the one-stage surgery. I insert the endoscope and stimulate the GSPN and expose the 𝑾𝒆𝒃 triangle. Procedure was same. And then after cut the SPS, we open the Meckel cave like this. We just perform the subcapsular dissection with preservation of the normal fiber of the trigeminal nerve. We, of course, reach the infratemporal fossa like this, and also reach the posterior fossa. So postoperatively, all tumor was nicely resected out like this. If the size of tumor is large, but this approach very useful for safe resection of the tumor. This is a 𝑃𝒊𝒂𝒓 meningioma, but also we applied this technique and safely resected out. We skipped the surgical video, but also tumor was resected out very safely. This is a petrous apex meningioma, also resected out through the endoscopic keyhole approach. We published this technique to the JNS this year. I include a video clip. If you have interest, please check this paper. And also recently, we published another paper of the endoscopic keyhole subtemporal approach to trigeminal schwannoma. This paper will be published operative neurosurgery this year, include a video clip. Final talk is our endoscopic interhemispheric approach. This is a 𝑃𝒂𝒂𝒓 meningioma. If we insert the endoscope to the interhemispheric fissure, we can directly observe the 𝑃 and tentorium. So early devascularization can be achieved in case of such kind of the tumor. We place the patient to lateral position. So superior sagittal sinus lining like this. We put the small craniotomy and also insert the ventricular drainage to relieve the CSL. Then we make the craniotomy with a size of 3 by 2 centimeters, like this. Craniotomy was very small, but after opening the dura mater, we gently insert the endoscope to the interhemispheric fissure. Endoscope can offer the good view around the 𝑃 and tentorium. So we can achieve the early detachment of the tumor from the 𝑃 and tentorium. After cut the tentorium and 𝑃, we can mobilize the tumor like this. So all tumor was nicely resected out. Bone defect very small. So we can nicely resect it out the tumor like this. This is another case of the large 𝑃𝒂𝒂𝒓 meningioma, but the procedure is also same. We put the ventricular drainage and then put the keyhole and put the endoscope and continue the internal debulking, and the tumor was safely resected out. This is a post-op MRI. We can resect it out all tumor with preservation of venous, deep venous structure. So I will also publish the usefulness of the endoscopic keyhole interhemispheric approach. So today I will talk about two topics. One is endoscopic enonasal and the other is endoscopic keyhole transcranial approach. Those approaches can be very effective procedure for removing the various kind of skull-based tumor. Thank you for attention.
Thank you, Professor Goto, for your excellent presentation. It was very informative, and we appreciate your sharing your knowledge, Sensei, and your experience with us. Now, let's move to the Q&A session. Please type your question in the chat box, and we will ask them for Prof. Goto. Any question from the audience? Maybe before audience, Professor, any question from the panelists? Dr. Irwan, please. Yeah. Raise hand, Dr. Ibi.
In the Q&A, there is one question, Dr. Hadi.
Okay. Professor, from Dr. Reza Arifianto. What is your main consideration for performing endoscopic transsphenoidal approach for craniopharyngioma instead of the transcranial approach? Please.
Previously, of course, initial 100 case, I operated a transcranial approach. But when we try to resect the craniopharyngioma by the transcranial approach, always we have to resect the tumor between the space of the perforator. So surgical resection very difficult. After that, we resect the craniopharyngioma, about 120 cases by the endoscopic enonasal approach. In my experience, endoscope can offer the good view around the circle of 𝑰𝑺. So we can directly enter within the circle of 𝑰𝑺. It means all critical structure is lateral margin of the tumor. So dissection of the perforator or dissection of the critical structure from the tumor was usually very safe. So compare the microsurgery or endoscopic surgery, I prefer to use the endoscopic and nasal approach in my surgical experience. Thank you. Good question.
Nice. Nice, Prof. Second question from the Dr. Fani Gari. What is it? How you hold the endoscope in the keyhole approach, Professor?
Yes. Even in case of the keyhole, endoscopic keyhole approach, we use the whole hands technique. It means our assistant hold the endoscope and also insert to the one instrument. And the main operator use the two instruments. But to stabilize the hand, we set the arm holder. So our assistant stable the arm and safely and steady control the endoscope. Thank you.
Okay. Okay, Professor. Thank you, Sensor. Third question from Dr. Mikhail Asek. What kind of plate do you use for the endoscopic endonasal transclevar approach? What do you recommend it for neurosurgeon in a low-income country where we cannot find plate? For example, Indonesia, maybe. Low-income country. Please.
Of course, surgical indication should be modified in each country, of course. But basically, the transcribal approach very useful for resection of pure lower cribal meningioma. Because in case of the lower cribal meningioma, all cranial nerve shift to the lateral margin of the tumor. So I use the endoscopic transcribal approach to detach the tumor at the early stage of the surgery. It's very useful for safe resection from the lower cranial nerve. But the problem is that when we drill out the cribus, we encountered some venous bleeding, or we have to water tightly seal the dural defect. So we need the flow seal or surge flow or some material to perform such kind of the surgery. I know that in Indonesia, you cannot use the flow seal or surge flow. In such situation, of course, a bit risky or dangerous.
Okay, Prof. Fourth question from Dr. Dishol. Thank you, Professor. Do you have experience of resection of pineal region tumor using pure endoscopic transcranial approach?
Sorry, I can...
experience of the resection of pineal region tumor, Professor. Pure endoscopic transcranial approach.
Yeah. Of course, I know we have the two types of the keyhole approach. One is a keyhole microscopic approach. And also the other is keyhole endoscopic approach. Each approach has the advantage and disadvantage. Keyhole microscopic keyhole approach is a 3D image, but it's very difficult to handle the microscope to see the blind corner. Endoscope approach is a 2D image, but endoscope can offer the panoramic clear view. So in my impression, to perform the keyhole approach, endoscopic approach is better than the microscope for the especially beginner of the keyhole approach. It's my impression.
Okay, Prof. Thank you. 5 question from Dr. Irwan. Very excellent presentation, Goto Sensei. One question, you have very clear view. How to get very clear view during endoscopic approach, Professor?
Also, maybe difficult question, but of course, to keep the surgical field clean is very simple technique. We have to just meticulous coagulation of the bleeding. We stop the bleeding step by step. It leads to the clear surgical field. So when we cut the skin, of course, we have to stop the bleeding completely, and then cut the dura. We of course coagulate, stop the bleeding, and step by step to reach to the deep side. So finally, we can make the clear surgical field.
Yeah,
Very
important is
simple.
very clean ya, Prof ya. Before we is in the intern. Last question from Dr. Doni Wisnuwardana, Prof. Goto. Meningioma tuberculum in the middle, and you can do both procedure, keyhole transcranial and endoscopy approach. Which one will you prepare the choice?
This is also very difficult question. In case of the tuberculum meningioma, we can access many by the many approach. Of course, we can reach the endoscopic and nasal, and also can reach the endoscopic transcranial approach. So we choose the approach based on the attachment of the tumor. In some cases, the attachment of the tumor reach to the lateral side of oblique canal. In such situation, I prefer to select the keyhole endoscopic approach. But some tumor, the attachment is not large, just located in the midline. In such situation, endoscopic approach very useful. So we have to select the suitable approach depend on the considering the each situation of the tumor. Thank you.
Okay, thank you, Sensei. Some question in the chat box, Professor, because the time is limited. I think you direct answer in the chat box, Professor. Thank you for your presentation and your discussion in second session. Maybe we continue to the third session. Please, Dr. 𝑑𝒂𝒂𝒓 for the moderator and the speaker with Dr. Selvi. Time.
Yes. Thank you. Thank you. Can you hear me?
Yes, very clearly.
Yeah. Yes. Thank you, dear. So this is the third and last session of the ISMINS AWCS collaborative webinar. Thanks, Professor Asra, and thanks, Professor 𝑦𝑺𝒑𝒂𝒂𝒓 for giving me opportunity for moderate these sessions. Then you already saw the best hands of Dr. Tokyo Goto's videos. They are very lucid and interactive and very catchy, so that you can learn and more things. So I'm going for the next and last talk for Professor 𝑺𝒑𝒂𝒂𝒓 on the talk on complications of endoscopic skull-base surgery, how to prevent. So Dr. Selvi is a skull-base and neuro-oncology division head at in National Brain Center Hospital, and she is a co-chairman of WFNS Women in Neurosurgery. She is also secretary of Indonesian Women in Neurosurgery Committee. She is a surgical education committee member of North American Skull-Base Society. So without wasting any time, we will wish to learn more from Dr. Selvi. So over to you, Selvi. Can you please share your Skype and screen?
Thank you very much, Dr. 𝑑𝒂𝒂𝒓, for the kind introduction. And it's very good to see everyone again. And I'm very grateful for the opportunity to share some of the things that we do here in Indonesia, which is, of course, very basic compared to what Goto Sensei that already presented before. So I think for all this talk, it's a very nice ending to discuss about the complication avoidance in the endoscopic endonasal skull-base surgery. Because as we know that our purpose is to get the functional neuro-oncology balance. So while we're thinking to get the maximum safe resection, we need to think how to preserve the normal pituitary gland and surrounding neurovascular structures. And we also know that in the management of tumors surrounding in the pituitary region, we know that we have several weapons. It's either the transcranial approach, transvenous approach, either the endoscopic or microscopic, and also radiotherapy, and some would only need medication. So we need to know about this beforehand and keep in mind that if complication might happen, then we can think and use other weapons that we have in our armamentarium. And this is the ideal, the innovation, development, exploration, assessment, long-term paradigm in the Scott's parabola. I think it was introduced in the beginning that when it's a promising idea comes, then how if it's possible to use continuously. And now we are going to talk about how the complication discussion and management. This is very important to have like an honest data sharing, and then we can discuss how to overcome each complication that might happen. Talking about complication is not easy, but it will be very useful, especially for the young and starting scalp surgeon. So first, what we need to do, of course, to identify the potential.
Professor, your
Yes?
screen is not going on. This is your first slide.
Ah.
It is not moving.
Oh. Okay. Maybe my Wi-Fi.
Yeah, please.
Is it moving now?
No, no second slide. Only this one is coming on.
Oh. Okay.
Yes, yes. Now we can be. Yeah. Yes.
Okay. Is it? Can you see my screen?
Yes. Yes.
So this is the Scott's parable that we've been talking about, how the complication discussion and management is important, and honest data sharing about our complication and how to avoid.
Professor, sorry to interrupt you. Again, the slide is not moving.
Ah. Now, is it moving?
No,
no, Dr. Hasbi, no. Maybe try again to, yeah.
Yeah. You can go from third slide and you can go play.
How about now?
Yeah. But
Is
okay.
it moving?
Yeah,
No.
it's clear now.
It's moving here. Yeah. Okay. So maybe I'll just not play the slide and put the presenter view instead.
Okay. You can share it on this.
Okay, let me try.
Yeah, please.
Is it sharing? No.
No. Yes, it's right now. Yes.
And now? Is it moving?
Yeah, and you can move it one or two slide again, at least.
Is it moving?
Next slide, please. Next slide.
I already put next slide.
Yeah, next. Is it possible? Is it okay? Again, it's stuck.
Not moving, I guess. So I think I'll just stick. Yeah. Okay, I think I'll just stick at this slides, I guess. Yeah?
Yeah, it's okay now.
Yeah, sorry. So I would like to continue. So first, what we need to do is to identify the potential complication. So is there any patient specific, yeah, it's moving, right? Yes. Yeah. Is there any patient-specific risk factors, and how is the anatomical variation? And how about if there's an equipment failure, do we have any backups? And how about if surgical errors happens? So in the beginning, this is a paper from Dan Kelly. So he was talking about the sinonasal approach. So during the sinonasal phase, we are using the nasoseptal flap or either the rescue flap. So there are some discussion whether it will decrease the olfactory function, while other reported that there are no decrease in olfactory function. So I think the limit would be to know where to cut and which one to save, so that we can have less complaint after the surgery. And then in the stellar exposure, the paper emphasized the needs to use the Doppler probe for ICA localization back and forth. And in the resection, need to discuss that the pseudocapsular dissection and also the normal gland identification is very important. And for the cellular and skull-based reconstruction, then we need to think about the graded repair of the possible CSF leak. So first, we need to prepare in the preoperative planning. The effective preoperative planning involves a multidisciplinary approach, including the neurosurgeon discussing with the ENT and also the radiologist. So we need to have the comprehensive patient evaluation, high resolution imaging, and then if it's possible to use the navigation, then we can make a 3D models beforehand, and then we need to do a risk assessment and to prepare for the contingency planning. So these strategies help in anticipating complication and preparing for unexpected scenarios. So especially for countries like Indonesia, and I believe also in India, please correct me if I'm wrong, Dr. Deepak, but the tumors that comes usually already pretty late. So we got a lot of giant size tumors coming. And that means that we need, that it's more challenging for us. That's why we need to do a very thorough preoperative planning. Grading system will help. And beside the neuronavigation that provides real-time guidance, the fluorescent guided surgery also can improve the tumor delineation, and also employing the angled endoscope allow for better visualization. Intraoperative monitoring is also crucial for detecting and responding for complication in the real time. So we usually use the monitoring based on the location itself, 346 SSEP, and then lower cranial nerve, MEP, whatever needed to be monitored based on the preoperative planning. And also if it's needed, if we want to check how is the vascular structure around the tumors, usually afterward we can also use the ICG to see that if everything is intact, or is there any vascular that coming right through the tumors and not actually normal or perforators. So this is very important. So in the patient selection, if we are in the early stages of training or starting, then we need to start selecting adult patient and the lesion that's confined to the sella, and also for the patient that has well-pneumatized sphenoid sinus. And as we progress, then we also need to think about the hypertrophied nasal mucosa. Next, then we can start doing the complex cases such as the large suprasellar extension, cavernous sinus invasion, dumbbell shape, recurrent tumors, which also make it harder for redo surgery, and also giant tumors. So the knowledge of anatomy and imaging is very important. So in the CT scan, we need to identify if there's any deviated septum. And if we send the patient to the ENT beforehand, will also helpful. And if we using a team-based approach, then intraoperative, we will have a thorough discussion either from the neurosurgery part and also the ENT part. And we can also check if this patient has a sinusitis, how is the intercarotid distance, and is there any destruction of the stellar floor. We need to always check about the T2 for the consistency, extent of invasion, and we need to predict if there will be any difficulty in surgery. And for the anesthesia technique, this is what was being suggested in the recent paper, that to reduce the bleeding, we can ask to lower a little bit the blood pressure, and then use the surgical packing in the throat. Head can be turned 50° toward the surgeon, 50° lateral flexion, and then parallel chin forehead line. 0 or 30° endoscope with the external sheath, and then the suction coagulator, curve suction. If we have this, then it will be good to just be prepared before surgery. So we need to have proper orientation of the endoscope all the time. Sometimes if we change the scope to 30° and then working with two surgeons, usually it will need adaptation. So it's very important to have a partner that goes that work together for some time to start with simple cases, then go to more complex cases altogether. And we always also need to know and understand that we need to do the gradual transition from the microscopic to endoscopic, and not like do it overnight. And acquiring hand-eye coordination and endoscopic surgical skill in lab on models or cadavers if possible. And then stepwise progression and knowing tips and tricks. For example, like attending this webinar, I get more and more tips and tricks and technique from Goto Sensei. And there's another paper reminding that the checklist is very important in surgery. So if we have a proper checklist that we use it in our OR all the time, with every personnel knows, then we can be very comfortable during surgery, because we know that everyone know what to do if any complication might happen. This is what our OR looks like. So usually I will do the surgery as a team-based approach with my ENT, and this is my anesthesiology. And then we always have our intraoperative monitoring neurologist with us here. And as for the surgical checklist, so my nursing team also already made like a small checklist here on what to do and when to give, just in case if there's a change in nursing. I think this is very helpful, especially for the young and starting to perform the endoscopic procedure. Then you can have more concentration on the surgery, and you can count on the system to continue going while you are doing the surgery. And in the positioning, we need to, of course, remember the ergonomic position for the patient and also for the surgeon. And we need to think to prevent the DVT, where the sharp edges and the possible needed graft already grafted in the beginning. And then anesthesia, we are using the Connacht just to make sure how deep the sedation is. And then for the nasal, then we usually also add some xylocaine afterward to reduce pain after surgery. So for the intraoperative guidance in the sphenoid stage, it's very important to open wide caudal and medially for the sphenoid ostia. And then we perform the posterior septectomy and then remove fomer. We do wide sphenoidostomy, and then we will mark the midline by fomer. And paramedian septum, usually the space for ICA or optic nerve. So remove in that area carefully. In the stellar stage, perform the drilling, dry drilling as hemostasis. And also for the cellular floor removal, we usually do the axial drilling. So we try to do the blue lining. So we find the 4 blue lines, the bilateral cavernous, and then the intercavernous anterior and posterior. And then coagulation and excision of the dura. And for the tumor removal part, then basal and inferior remove first, and then the suprasellar descend gradually. A uniform bulge and pulsating diaphragm indicates complete removal of the tumor. So try to be very gentle with the diaphragm, because it will be very helpful to make sure that you already remove all the tumor out. And close contact endoscopy to identify the normal gland. It's also possible, so that we can see the branches of the vessels instead of the vessels in the tumor itself. Angled endoscope can be used to screen the tumor remnants at the medial OCR under the anterior lip of the dura. That's where usually it's held back, and also the superior intercavernous. So the bimanual dissection and sequential maximal excision of tumor under vision in piecemeal fashion after dissecting it free. No blind dissection or pulling should be done. Using extended approach and neuroimaging in large complex adenomas. And avoid the arachnoid tear, so that we can also prevent the CSF leak afterward. For the cellular reconstruction, we can use 𝑰𝑺𝑴𝑰𝑵 also to check for any leak, and single large piece of fat if needed. But I think it depends. I don't use it all the time. I only use it if it's in the clival region to fill in the gap. And then multi-layer closure is important. Of course, the nasoseptal flap is a very crucial component here. And this is the surgical steps. I don't know if I can. Can you see my screen moving, Dr. Deepa?
Yes, it's moving, but it's not
Okay.
show. Video is not playing.
Not playing?
Yeah,
okay.
it's not playing. It's just stuck.
Okay then.
Yeah. You click there only. Yes, now it's playing.
Yeah, correct. But I just cannot control where. Yeah. So I usually cut the middle turbinate, and I use the mucosa of the middle turbinate as a graft afterward for the only closure. And also that helps that I can make sure that the middle ostium is always open, so that I try to prevent if there's any complication of frontal sinusitis, because the middle ostium was closed. If I do like extreme lateralization of the middle turbinate. And this is yeah, I'm very sorry, I cannot put this in a fast forward. So here's what we already talked about, the axial drilling, and then we try to take out the tumor more with dissector afterward. And then after a thorough Doppler investigation, then we know that in this part we already in the cavernous, and also in this part. Then we start opening the dura mater after the coagulation. The internal debulking, I think the principle is the same as if we are doing it transcranially. And then we take some for the samples. And I really like to use the double suction technique to do more resection, starting at the 6 in the below part. And then when we have enough, then we can identify the capsule and try to dissect, to do the subcapsular, to make sure that we take the tumor all out. and we can actually identify that in this in the back is the normal pituitary gland. We can then continue if until we see the arachnoid coming down. Okay. Yeah. This is also same video, but I think it's longer, so I'm gonna skip that. And for the extended approach, especially for the tuberculum cell meningioma, we of course after the resection we try to preserve the normal gland, and then we investigate the neurovascular structure afterward to make sure that even the superior hypophyseal artery is still intact. For the multi-layer closure, we are using the inlay, onlay, overlay technique. The inlay, we're using the DuraGen, and then the onlay, we're using the mucosa from the middle turbinate, and also some of the sphenoid mucosa. We put it back after we clean it out, and then a nasoseptal flap in the end, and if needed, we will use the balloon catheter. And the fibrin glue in the end. So the sinonasal complication that might happen is the alar injuries, the nasal burns, the posterior epistaxis that can happen in the early period or in the late period, anosmia, and then mucosal or the cosmetic deformities. And this can be avoided by packing of the nasal cavity with solution with adrenaline and xylocaine. That's what we're using now. And then we spend more time in the sphenoethmoidal recess widening and gently in the handling of the mucosa, avoiding the injury by passing the instrument under the endoscope guidance, involvement of an ENT surgeon, and then sucking the blood in choana in between to remove the block choana effect. It can also happen where the patient will start complaining that doesn't feel like something's blocked in the pharynx. And then adding antibiotic, sometimes we need to do that, but we don't do it routinely. And then not leaving any foreign body in the sphenoid sinus. And this is from the paper. I think the sinonasal outcome test, the SNOT-22, is currently being used to check the post-operatively if there's any very concerning complaint. So there's 22 questions, and then they need to grade it. Either it's very disturbing or it's only mild disturbance, or if there's nothing at all. So in the papers, it showed that over time, it will improve at 6 and 12 months. So we should remember that intraoperative complication can be happen as a cerebrospinal fluid leaks, and then vascular injuries and or optic nerve damage. A well-coordinated surgical team is essential for managing these challenges effectively. Just want to remind the sphenoid septation and also the relationship with the ICA can also be very helpful, especially if we don't have any neuronavigation, then we can know by predicting where the ICA actually is. So if we still have time, maybe I'll just present one more case about the ICA injury in the clavicle chordoma in the 58 years old male. I'm not sure if, so I need to run this one by one. So we decided to perform an extended endoscopic approach. Is it moving?
No. Again
No?
stuck.
It's getting stuck. Okay.
No.
Okay. Okay.
Again go back and
Okay. Because it's
now
a
you can
very
click it.
yeah, but it's quite long video, and I don't think I can.
Okay.
Yeah. So what happened in this surgery is that there are several reported about how the ICA injury actually happened. One is by using excessively when using the Kerrison, and in this surgery particularly because of the location, it's quite low, so I need to mobilize in the muscle area. So after using several scissors, it's very hard, so I started to use the monopolar. So while I'm using the monopolar, apparently it was the lacerum portion of the ICA, then it caused the ICA injury. But luckily everyone was very cooperative and helpful at that time, and everyone is quite ready. So we can, with the teamwork, we can control the situation. So what we need to do if there's an ICA injury, then we need to communicate, especially with the anesthesiologists and also the nurses. And we need to expose even the surgery, even the surgical area even more, to make sure where actually the injury are, and not just doing the packing itself. It was actually in the video where we used the big suction, two big suction, and then we try to localize where actually it's a puncture injury to the ICA. And then after we recognize where the localization is, then we will put the muscle, and we will ask one of our team to take out the crushed muscle, and then to stop the bleeding, and then do the multi-layer, and then hold it. Actually, there's a paper coming out from Toronto that I think starting on how to act ACT during the ICA injury. So the recommendation would apply firm pressure for 10 to 12 minutes. And then after that, utilize the hemostatic agent. And then alert the interventional radiologist. So we need to socialize the protocol, the ACT protocol, how to alert, control, and transfer the patient if this kind of complication happens. Yeah, and then here's the DSA, the angio afterward. At that time, it doesn't, we do the nasal packing, and then we open the nasal packing a couple of days afterward, also in the angio, just to make sure if there's another bleeding, then the intervention will be ready to perform, to help, then we can take it out safely. After that, then the patient went home, and we then planned for the second surgery. After discussion with several of mentors, then we decided to go through the transcranial. So I'm so sorry, I cannot put the two videos at the same time. So we decided to go transcranially, and apparently the tumor is a very calcified tumors, and I'm also not sure how to manage to take this out safely with the extended endonasal approach when we see that how attached it is to the surrounding structures. And we even at some point using the drills and also the Carrison to take the tumor out. And there are some loop of ICA and all the lower cranial nerve 7 and 8 are being exposed, and we take out from the very, very small corridor piece by piece because we cannot use any other tools at this very moment. And it's a very humbling learning experience that when there's a complication happen, then we still need to remember that we don't only have one weapons, but we know that we can always perform or come back another day from another transcranial approach, or even discussing if if radiation is possible. So we need to put in mind that there are no one only way to do something. So if there's some complication happen, so this we can see that the scissor cannot even do anything to the tumors, and then we take it with the Carrison behind the ICA loop. Yeah, so this is a very expensive and humbling learning experience, especially for me and the team here, that when one doesn't work, then there's another way. And we know that as long as we keep going and pushing forward, hopefully we can help our patient even more. So I don't think we have time to talk about the other complication, other the diabetes insipidus, the electrolyte imbalance, the panhypopituitarism that might happen, and then the infection epistaxis that can actually be prevented by having a very good post-operative care with a very good standard, with a very good team. And I cannot emphasize enough the importance of team in taking care of our patient. And continuous education and training are vital for skill development in endoscopic skull-base surgery. Investing in training reduce the likelihood of complication by enhancing surgical proficiency. So this in the left picture, this is our endoscopic courses in our hospital January last year, and hopefully next year we will have Dr. Carter and Dr. Wang coming to our hospital, and we would like to welcome everyone to join us. Thank you very much for the opportunity. I'm very sorry for the slides that I cannot share or the videos that's not moving. Thank you.
Thank you, Professor Selfie. Is the better insights given to the how to avoid the complications and how to prevent it, and what are the complications mostly really matters in the endoscopic transsphenoidal surgery, starting from nasal stage, sphenoidal stage, then cellular stage, and then intraoperative complications. So definitely, pituitary gland identification, then tumor removal, carotid artery localization, and repair is the 4 key landmark that you taught us that is most important for the complication avoidance in pituitary surgery. Definitely. Can I, as any there are questions for the Dr. Selfie? Can you? So there is one question, Professor Selfie. In preoperative planning, do you exactly identify by MRI the location of the pituitary gland in relation to the cellular supracellular mass lesion?
Thank you. So we know that it should be the one that enhanced the most. That's the standard. But of course, 36% of the patient that comes to our hospital is the giant tumors. And I know the number is too big, but I think because in our country, it's not very easy. So usually they just come very late. So in the very, very big tumors, it's not very easy. That's why intraoperatively, we try to use the ICG to to check if we are concerned that it's the normal gland, then we would like to try to preserve that as much as we can, because in our country, of course, the medication, the hormonal replacement therapy is very hard to get. And some of our patients was actually not coming from our big island and from the other, like the eastern part of Indonesia, that maybe they don't have access to that. So whatever we are doing in the surgery will define how their quality of life afterward. And we always, at least usually in the clinic, I always mention to my patient that for me, because we know that most of these patients are benign, I would rather leave some the tumor if I was concerned that it's the normal pituitary gland, because as we know, the quality of life one patient is very dependent on how our pituitary functioned. And if we don't have the ICG, we can also use the contact endoscope. So you just try to move the scope very close to the structure that you suspicious that it's the normal gland. Then you can see that the vasculature is like branches. So it's not like the tumor when it doesn't have any like a pattern at all. So I think that can help.
Yes, definitely. Tumor gland preservation should be the must in case of majority of the case of the endoscope pituitary surgery. So definitely ICG also helpful, and that contact endoscope is also definitely helpful. So another question, in case of extended endonasal surgery for children with poor aeration of sphenoid sinus, what can we do minimize the complication? Is the 3D modeling or virtual reality helpful for stimulation of stimulation in such cases?
Okay.
Basically, CT scan for your this one before the planning of the surgery in children's. How do you plan your surgery in children's? How to miss for the salar sphenoid sinus? How can you plan your surgery in children's with this one?
Yeah, so up until now, I think my youngest patient is around 9 or 10. So I don't really have a very young age.
Okay.
We do have one cases, but then because I was concerned that the scope itself, I cannot move freely there. So I choose the transcranial. I think it's also important to be more wise in choosing the approach based on the team that we have right now.
Yes, the right approach is a must for the right operations, depend upon the expertise and also everything. So, as there is no question, can I ask one questions to you?
Yes, please.
Yeah. Do you think extent of resection of the tumors in pituitary surgery matters? Like in glioma, you said that is the extent of resection is matters. But in pituitary tumors, do you think extent of resection matters?
For the recurrence, yes, but yeah, as we know that there's another 9 subtype of the pituitary tumors, and we know that if the silent corticotroph, then usually it will just keep growing and growing. But we try, yeah, so we try to take as much as possible for sure. That's our goal, but we will not if it's harmful or possible harmful that we cannot take care and it might invite any complication, then or I'll just come back another day.
No, definitely in functional tumor, you should be goal as
functional,
achieve his goal. Non-functional, you can leave it. Depend upon your because in era of SRS, you can leave some tumors behind the cavernous sinus or within the carotid nucleus. Okay. So, what is your strategy for skull CSF leak repair? In my patient, if the CSF leak repair happens, I go again, recurrent CSF leak. What will you do? You operated the case and again the leak happens, then again the leak happens, you don't have any turbinate flap, you don't have any Haddad flap because it is necrosed, then what will you do?
Yeah, so I think the vascularized flap is very important. So I need to find a resource to get a vascularized flap. I think the biggest flap that you can get, of course, from doing the transcranial and then do the drillings and then take it from below if needed, if it's already like recurrence a couple of times. So that's why in the beginning, we shouldn't take it very easy saying that, okay, this is not going to leak, but because I think the first surgery is very important, and you need to be very thorough and thinking, if I leave this part out, then if it increase the risk of leaking, then I will just do as much as I can. Yeah. And for the posterior fossa, I always put the lumbar drain for a couple of days just to make sure that it doesn't leak. Yeah.
Okay. So do you think any shunting operation means CSF diversion, like you do use VP shunt for your recurrent CSF rhinuria cases of post-pituitary?
Here
Any experience?
you could know. Up until now, with the inlay only overlay technique, and also applying or choosing when to use the lumbar drain, when to take it out, I think we are very okay with, so we don't have any leak, like a very big leaks that usually if there's some small post-nasal discharge, when we give the acetazolamide, usually it's just resolved.
Okay. Okay. Thank you, Professor. Very good insights and very good lectures, and very lot of learn from you. Okay, over to Professor Asra.
Sensei also can give some comments, Dr. Chipa. Goto Sensei has more experience in this, I guess.
Yes.
Okay. Thank you, Dipa. And also thank you, Dr. Selvi, for your nice presentation. So, and also, I'm also thank you for all the speakers, Professor Ishihara, Professor Goto, and also Dr. Selvi for your inspiring lecture. So before we end the session, I want to ask Professor Yokato, as our president of ISMIN, to give some comments. Please, Professor Yokato.
Professor Kato.
Oh, Professor Yokato, you are still here? Oh, okay. Thank you. I think Professor Yokato is not here. So for all participants, again, thank you very much for your participation in this webinar. And on behalf of the ISMINS and also Professor Yokato, I would like to say, thank you very much. And please, you can join for the next our webinar in next February. Okay, thank you very much.
Thank you.
Bye-bye.
Thank
See you
you.
later. Yeah.
Thank you.
Thank you. Thank you, Professor Asra.
Pak Asra.
Thank you.
Prof. Goto. Thank you.
Thank you, Professor Goto.
Hi,
Appreciate.
Sushiro.
Thank you, Professor Goto. Thank
See
you.
you next time,
Bye-bye.
Professor Sensei.
In your
Hi.
future.
Mahadi.
Bye.
Service.
Hi,
Goodbye.
Dr. Sensei. Bye-bye.